Discussion on peripartum cardiomyopathy. Peripartum cardiomyopathy is diagnosed when features of dilated cardiomyopathy develops in the last 1 month of pregnancy or within 5 months of delivery. Clinically, there are features of left ventricular dysfunction of varying severity. Sometimes they present with pulmonary edema or cardiogenic shock. The risk of peripartum cardiomyopathy increases with increasing maternal age. Echocardiography documents the severity of left ventricular dysfunction. Peripartum cardiomyopathy constitutes about 4% of all cardiomyopathies. The incidence varies from 1 in 3,000 to 4,000 pregnancies. It is a form of dilated cardiomyopathy and contributes to 9% of maternal mortality. Mortality estimates range from 25 to 50%. Future pregnancies are better avoided, though safe pregnancies in those who have fully recovered from the left ventricular dysfunction within 6 months have been reported. Residual left ventricular dysfunction is a definite risk factor for significant worsening in future pregnancies. Even those who have recovered have been shown to have a drop in ejection fraction during future pregnancies. There could be a genetic background for at least those cases of peripartum cardiomyopathy which do not resolve in the usual pattern in postpartum period. This has been suggested by a study which found first-degree relatives with undiagnosed dilated cardiomyopathy for all the 3 peripartum cardiomyopathy in their database who did not show full recovery. Genetic analysis showed that there was a mutation in the gene encoding cardiac troponin C in one of these families. In addition, they also evaluated 90 of the families with dilated cardiomyopathy in their database and found that 5 families had peripartum cardiomyopathy patients. The authors concluded that in some patients, peripartum cardiomyopathy may be an initial manifestation of familial dilated cardiomyopathy and would benefit from family screening. Another study evaluated both peripartum cardiomyopathy that is occurring in the last month of pregnancy to 5 months postpartum and pregnancy associated cardiomyopathy with onset of dilated cardiomyopathy earlier in pregnancy. They studied 4,110 women from 520 pedigrees in their familial dilated cardiomyopathy research project database and found 45 cases of peripartum cardiomyopathy or pregnancy associated cardiomyopathy. 3 cases of peripartum cardiomyopathy were familial with mutations in MYH7, SCN5A and PSEN2. 2 of the sporadic cases of peripartum cardiomyopathy had mutations in MYH6 and TNNT2. 1 case of pregnancy associated cardiomyopathy had a mutation in MYBPC3. Diagnostic criteria for peripartum cardiomyopathy are 1. Development of heart failure in the last month of pregnancy or within 5 months after delivery. 2. Left ventricular systolic dysfunction with ejection fraction less than 45%. 3. No other identifiable cause for heart failure. 4. No recognized heart disease before the last month of pregnancy. German cancer registry data has shown a 16-fold risk of cancer in those with peripartum cardiomyopathy. According to the report, 21 of the 236 patients had cancer, of which 12 had cancer diagnosed before peripartum cardiomyopathy. 11 of them had cardiotoxic chemotherapy. Of these, 17% fully recovered cardiac function compared to 55% of peripartum cardiomyopathy patients without cancer. Of the 10 patients who developed cancer after peripartum cardiomyopathy, 80% had left ventricular ejection fraction of 50% or more after cancer therapy. Authors mentioned that the high prevalence could be due to genetic factors. They suggested genetic testing and screening for heart failure in pregnant women who had cancer and screening for cancer in women who had peripartum cardiomyopathy. Use of bromocriptine for the treatment of peripartum cardiomyopathy has been there for some time. Prolactin can be cleaved into a toxic 16 kilodalton prolactin fragment also called vasoinhibin, mediated by oxidative stress. This prolactin fragment has a role in driving peripartum cardiomyopathy, hence the role of bromocriptine in the treatment of peripartum cardiomyopathy. Suppression of lactation is a concern while using bromocriptine for peripartum cardiomyopathy. In a pilot study, 10 patients each with peripartum cardiomyopathy were randomized to open-label bromocriptine with standard heart failure care or standard heart failure care alone. One patient died in the bromocriptine group while 4 died in the control group. Significantly fewer patients in the bromocriptine group experienced the composite endpoint of poor outcome defined as death NYHA functional class 3 or 4 or left ventricular ejection fraction less than 35% at 6 months compared to controls. Cardiac magnetic resonance imaging did not show any intracardiac thrombi. As the infants of bromocriptine treated mothers could not be breastfed, they were also studied. Infants in both groups showed normal growth and survival. German Peripartum Cardiomyopathy Registry has also demonstrated the beneficial outcome with bromocriptine. The study showed a high recovery rate of 96% in patients on a combination of beta blocker, angiotensin converting enzyme inhibitor or angiotensin receptor blocker, and bromocriptine. Positive family history was present in 16.5% of cases. They suggested the role of several biomarkers including cathepsin D, the enzyme that generates 16D prolactin fragments in peripartum cardiomyopathy. Here are the first set of references. Second set of references are here. Third set of journal references. Thank you for watching this video. Please subscribe, like, share and post your valuable comment below this video.